1895, which was just a few years before I was born, Wilhelm Conrad Röntgen, like many scientists of his day, was busy studying cathode rays. Well, now, we know cathode rays today to be electron beams, but in those days, they were just mysterious things that occurred when you applied an electric current across an anode and a cathode and an anode. And a lot of people were very interested in the fact that these cathode rays, whatever they were, caused chemicals to fluoresce, various chemicals to fluoresce. And he wanted to test the effect of cathode rays on a chemical called barium platinocyanide. You do not have to know any of this stuff. All right? This lets you know that things happened before you were born. All right? Now, cathode rays cause various chemicals to fluoresce when brought close to the tube. He had his little sheet of cardboard covered with barium platinocyanide, not close to the tube. He had it 10, 15 feet away as he was making adjustments to the tube and turning it on and seeing about certain things. So he did not expect this to fluoresce. So he turns on his tube, and yet in a dark room he sees that his little piece of cardboard is fluorescing. Now he knows that cathode rays can't go that far. So he decides there must be some other kind of ray that is causing that to fluoresce that can travel further than cathode rays. He didn't know what it was, so he gave them the name we all give things that we don't know what they are. He called them X-rays. And he said, I want to find out what will block X-rays. And he took various items, including pieces of lead and things like that, and as he walked over to his cardboard with the fluorescing barium platinocyanide and started to put things over it to see if he could block these X-rays, he saw his hand. He saw the bones of his hand shown through, reflected in the fluorescence of that sheet of paper. And that was the discovery of X-rays. Within a year, they were used in medical practice. And 6 years later, he won the very first Nobel Prize for medicine. So this is not a trivial discovery that he made. All right, this is a schematic diagram of what a current X-ray producing machine looks like. Again, nothing you need to know for this course, but I'll just tell you anyway. Here's the cathode, and it sends its beam of electrons towards the anode, which in modern day machines rotates so it doesn't get too hot in any one spot. And when those electrons hit that anode, for reasons I certainly don't understand, they send off a kind of electromagnetic radiation, which we now call X-rays. And those X-rays go through a thing which narrows the beam called a collimator. They go through whatever you're aiming at, such as the hand in this person, and they land on a screen. All right. If it's a film, as is here, that film is usually covered, that film is covered in silver bromide, a little bit of silver iodide mixed in. And when the X-rays hit the silver bromide, they cause the molecule to dissociate into silver and bromine. And the silver gets deposited at the sites where the X-rays hit this film. Silver is not translucent, so you take this film out, you develop it or whatever, and you hold it up against light, and where the silver is deposited, it's black, because silver does not transmit the light. So where the X-rays hit that film, it's black, and all the other chemicals are washed away in the developing process. So where the X-rays failed to hit the film, it's white. All the silver bromide has been washed away. So that's the basis for what is, this just tells you that X-rays are in fact a little shorter wavelength than ultraviolet light on the electromagnetic spectrum. This is, one of the, if not the most important slide today. You have to know what looks white and what looks black and what looks gray to have any idea what you're looking at. And there are 4 named radio densities, they're called. There is bone, which is the highest natural radio density. That means the X-rays cannot or do not get through bone because of the calcium in it. Therefore, they do not hit this silver bromide layer and cause silver to precipitate. Therefore, when you develop the film, you wash away the silver bromide, and you can see right through where the X-rays failed to hit the film. The highest radio density is bone. The lowest radio density is air, because they don't stop any X-rays at all. So the silver deposits on the film. So we speak of air density and bone density. In between those two are most of the other tissues of the body, like muscles and blood and stuff like that, which are mainly water. It's made out of water. That's called either a soft tissue density or a water density structure. And they tend to be various shades of gray. And finally, the fourth radio density is fat, which transmits more X-rays than do water-based structures, but blocks more than does air. So the four densities are bone density, water density, fat density, and air density. And you pretty much can identify any density you see as one of those four. This is a chest film, and this film is put up here to point out a fifth density, a non-naturally occurring density called metal. This person has a bullet somewhere in their chest. Metals are yet a fifth, even greater radio density than is bone, and lots of people do have bits of metal in them from time to time. This also illustrates another fact, and that is, yes, bone is more radio dense than water or soft tissues, but if you have a very thin bone, like your ribs here, which are pretty thin, and you have a very thick water density structure, such as the heart, this heart's going to appear whiter than the bone will. So thickness makes an important contribution to how white or gray something appears. A very thick water density structure will appear whiter than a very thin bone. So that's something one has to know about. And finally, this picture illustrates to you, is meant to illustrate to you, this is called a plain film. All right? That's what I've been talking about. That all plain films are two-dimensional. They are squished flat. You cannot tell whether the film was up against this person's chest or the film was up against their back. We'll talk about more of this on Friday. It's a two-dimensional structure. There's no indication of depth here. And that means that I have no idea whether that bullet is sitting way up here in the front of the chest or there's a vertebra at the back of the chest. No idea whatsoever on this film. And that is why when you do many plain films, you take this view, which is a posterior and anterior view, and you take a lateral view to let you know where it is in the depth of the specimen you're looking at. And in this case, the bullet happens to be sitting deep to this person's manubrium, something you'll have read about before dissection today. So those are three things you have to keep in mind. There is a metallic density. It's two-dimensional, and those are the most important. All right, now the things that we have a basic of what causes things to be white or black or gray. We'll take a look at the spine. Spine is largely made up of bone. This I guarantee you know. If you don't know this now, then you better go home and study very hard tonight. All right. There are 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, 5 coalesced or fused sacral vertebrae, and 4 coalesced or fused coccygeal. I guess I wouldn't personally care if you didn't know how many coccygeal there were, but I think knowing 7, 12, 5, and 5 is pretty darn important. You also know that between each vertebral body is an intervertebral disc. We'll be talking about this more later. Here's here is a thoracic vertebra. I don't know why it's called typical. Maybe it's because there's 12 of them and not so many of the others. All right? Again, something you should know. There's a body of a vertebra. This is, by the way, anterior, up towards the ceiling. This is posterior, down towards the floor. So here's the body of a vertebra, the body of the thoracic vertebra, extending posteriorly from the body of the thoracic vertebra. These two little columns, short columns of bone, referred to as the pedicles, right and left pedicles. The two pedicles are short, and they end by joining these two more plate-like regions of bone called the laminae, which are obliquely positioned and head toward the midline, join one another to form the spinous, from which the spinous process emanates. From the junction of the pedicle and lamina in a thoracic vertebrae emerges the transverse process, to which the rib, with which the rib articulates. Also, from the junction of the pedicle and laminae in a thoracic vertebra is a part of the process that rises superiorly, called the superior zygapophysis. It's sometimes called the superior articular process, and it carries a articular facettal cartilaginous surface for articulating with what is not shown here, which is an inferior zygapophysis, or an inferior articular process passing behind the plane of the blackboard. But since this is a superior view, we cannot see the inferior zygapophysis. Not all vertebrae look just like a thoracic vertebra. Cervical vertebrae are remarkably different from thoracic vertebrae. Their bodies are shaped differently. The pedicles are very short in a cervical vertebra. The pedicles do not head straight backwards from the body. They go out at about a 45-degree angle. The laminae are quite long, and spines of most cervical vertebrae are split in two, what's called a bifid spinous process. Also, the transverse process of a cervical vertebra doesn't remotely resemble that of a thoracic vertebra. It's got two bars, an anterior bar, a posterior bar, ending in an anterior bar ending in an anterior tubercle, the posterior bar in a posterior tubercle, and I don't know if it's called intertubercular bar, I forget what the hell it's called, but it isolates a foramen, which is called the transverse foramen. There's nothing like that in a thoracic vertebra, but we'll see why. Lumbar vertebrae are less dissimilar, lumbar vertebrae, sorry. Nice oval-shaped body, nice short pedicles which head straight backwards, laminae, transverse processes, and superior and inferior zygapophyses. The articular surfaces of the zygapophyses tend to be more in a sagittal plane in a lumbar vertebra. They tend to be more in a coronal plane in a thoracic, and that very greatly influences the kind of motion you get at these joints between vertebrae. Now, here is a thoracic vertebra, but I've drawn in the rib. In development, this rib, in fact, was not a separate structure. It developed from the very same cartilage that formed the vertebra. And it grew out as a long cartilaginous extension of the vertebra. And then it later separates from the vertebra and becomes bony, a separate bony structure called a rib. But all the vertebrae have this rib-like process to start with. It doesn't get long in any other than thoracic vertebrae, but it exists as a short structure in the developing cervical vertebrae. And in fact, remember I called this a transverse process, but in fact, from the point of view of developmental homology, the part in yellow here is really the rib part of a cervical vertebra, the costal element of the transverse process. That's why, and here is the actual transverse process, and that's why I couldn't think of the name of that bar because I call it the costotransverse bar, reflecting the developmental side of things, but it probably has a real name that I can't remember. In the thoracic, in the lumbar region, also, like all the vertebrae, there's a costal element which doesn't grow as long as it did in the region of the chest and doesn't separate as it did in the region of the chest. So it's more similar to a cervical vertebra in that regard. And this is the part of the transverse process of a lumbar vertebra, which is the costal element. So it's interesting from a homology point of view. This thing we call the transverse process of a thoracic vertebra is not homologous to what we call the transverse process of a lumbar vertebra. It is the rib of in the chest that's homologous to the transverse process of a lumbar vertebra. The structure in the lumbar vertebra is homologous to the transverse process of the thoracic vertebra. It's just this little bitty thing right here. The sacrum, too, 5 sacral vertebrae fused together. Much of the sacrum is comprised of the costal element. And it's just this little bit here, which would be the true transverse process. Sacrum, because of their fused together, all sorts of new things, the opportunity arises to name all sorts of new things. The superior surface of the costotransverse element of the first sacral vertebra is called the ala, or wing of the vertebra. This is not as a result of fusion, but the anterior lip of the body of the first sacral vertebra. It's called the promontory of that vertebra. Now, as a result of the fusion, you've got all these holes coming out the back called dorsal sacral foramina, and all these holes seen on the front called ventral sacral foramina. You get crests, which I'm not going to bother to name here. And I point out that the fifth sacral vertebra, the laminae, never form properly, and you don't get a spinous process. You get a gap here where the laminae and the spine should be, and that's called the sacral hiatus. And the abortive lamina on either side of the sacral hiatus is called the sacral cornea. All right, we'll go through quickly the fact that the first and second cervical vertebrae are very, very different from even the other cervical vertebrae. Cervical vertebrae are different than thoracic, and the first and second are different from the others, cervical vertebrae. The first cervical vertebra is called the atlas because it supports the globe of the skull. Atlas was the Greek whatever, god or demigod that supported the earth on his shoulders. So the globe of the skull sits on top of the atlas. And its superior zygapophysis is really strange looking. It's just called the superior articular process. It's got no spine. It's got no body. Atlas has no real body because much of the body of the atlas has been stuck onto the body of the second cervical vertebra, which is called the axis. Axis because the atlas can spin around it. You'll learn more about this when you study head and neck. So instead of having a body, we just have an anterior arch for the atlas because most of its body is stuck onto the body of the second. We have a posterior arch. Tend not to refer to these as laminae. We just tend to refer to that as a posterior arch. There is no spinous process. There's a little bump there called a posterior tubercle. And I mentioned then the part of the body of the atlas that's stuck onto the second cervical vertebra. That portion is called the dens, which means tooth, or odontoid process, which means tooth-like process. And that allows the atlas to spin, as in turning your head in yes or no. No. Turning your head in no is the spinning of the atlas on the axis. Yes is spinning of the skull on the atlas. So you should be aware of those differences. Now, you put the vertebrae in the lumbar region. We're going to be focusing mainly on the lumbar region from now on because it's probably the most, well, that and the neck are both clinically significant. And I just put all 5 lumbar vertebrae together to point out to you that in between the pedicles of adjacent vertebrae is a space called the intervertebral foramen. That's how spinal nerves get out of the spinal cord. You saw that in dissection. Between the bodies of vertebrae are these things called intervertebral discs. Now we get to see an inferior zygapophysis that we couldn't see in the previous drawings. Here is the intervertebral disc seen in superior view. Again, well, not again, because I don't know if you remember this, but it is comprised largely of a circular, collagenous framework, which is called the annulus fibrosus, the fibrous ring, and stuck in the middle of that is a more gelatinous structure called the nucleus pulposus. Here's where you ask whether anybody did any embryology at all. You did. So the nucleus pulposus is derived from what in the embryo?
Oh, me?
Anybody, I don't care. He shook his head yes.
I think it's the notochord. I'm not sure.
You think it's what?
The notochord?
The notochord is absolutely correct. You're not who I was calling on, but it's even better. Great. The notochord, the remnant of the notochord is the nucleus pulposus. All right. So every disc looks like this. An outer thick ring of collagenous annulus fibrosus and an inner core of nucleus pulposus. Now, plain films. Plain films of the vertebral column are not very important nowadays. Nowadays, you'll see why. Because you really can't see that much in a plain film of the vertebral column. Here is a plain film of the lumbar column. Here's the sacrum down here. Here's the last rib, so that tells me that's T12. And now, many of the x-rays I'm going to show and CT scans I'm going to show from now on are not going to be labeled. And they're not going to be labeled for a reason. Number one, I want you to listen to what I'm saying, because I give you the reasons for identifying structures, and I want you to hear my words. That's what my daughter and her husband say to their little child, you're not my little children, but when their kids misbehave, they don't believe in hitting them like we did, like I did. They say, no, don't do that. Listen to my words. And this is supposed to impress some little kid that they're not supposed to do it. Well, I need you to listen to my words, not to read so much, what's on the side. All of these x-rays that are unlabeled, every one that I'll be showing, are on the website, labeled on the website. So you don't need to see them labeled here and need to see them labeled there. If you can't figure it out for yourself, you go to the website and you'll see them labeled. All right. Number one, I've already told you, is the 12th rib. You can see the various ribs coming down. There's 9, 10, 11, 12. And we get to the first lumbar vertebra, which has no rib. Number two, I think that's pretty obvious what it must be. It's a transverse process of a lumbar vertebra. In this case, number 3. Here's the transverse of 4. Here's the transverse of 5 on the patients. These x-rays are always projected as if you are looking at the patient, as if you're examining the patient sitting at his or her bedside or your desk or table or whatever. So x-rays are always projected since as you're examining the patient, this means this is always the patient's right side and this is always the patient's left side. So this is the person's right transverse process of L5. This is the person's left transverse of L5. All the left 4, 3, 2, pretty hard to see 1, but it's possible. Number 3, what we are now seeing is an end-on view of the spines. Spines are these flattened processes with a rim of thick bone on the outside and a little marrow or less thick bone on the inside. So you're seeing the rim of the thick bone on end that form the spines. There's another one right there. There's one right there. So you're seeing, these are the spinous processes. And more obvious, however, is number 4, which is seen on end the cylinder, which is the pedicle. Pedicle is a thick cortical bone cylinder with a little marrow bone on the inside. And we see, because we're seeing it on end, the thick cortical bone of the pedicle here. Here's the thick cortical bone of the pedicle there. Here it is there. Here it is there. Here it is there. And we see them on both sides too. And aside from these 4 things, you really can't see all that much. Here, you see the body. Here's a lateral lumbar film. I've just numbered the bodies here, things that you should be able to clearly identify. Obviously, the portion of the vertebra that extends backwards from the superior half of the body, which is the pedicle. The part which extends upward, superior to the body, which is the superior zygapophysis. The part which extends inferiorly from the pedicle, or from the arch, this vertebral arch down, which is the inferior zygapophysis. 4 is barely visible in this x-ray. The spine, here's one spine of L4. Here's the spine of L3, spine of L2. Why, since the spine is a bony structure, why does it not look very dense here? Oh, yes. No, you can tell me.
Because it's thin.
Because it's thin. Absolutely right. If you have very thin bone, it just doesn't look that white. All right? The body's very thick, looks very white. And most of the vertebral arch is very thick and looks very white. And 5 is the space or the gap between the pedicles of adjacent vertebrae, which is called the intervertebral frame. It's filled with water density structures, which are spinal nerves, but they don't show up clearly because they're water density and don't separate well. Well, we'll talk about that in a second. This is a anteroposterior view of a thoracic spine. You can barely see anything. These are rarely done because they don't. If you're going to look at it, you're going to look at it for ribs, more the back posterior parts of ribs. I just pointed out to you how thin the discs are. Intervertebral discs in between the bodies are quite thin in the thoracic region. But it's not a terribly useful x-ray. Here's a lateral view of a cervical spine. I've numbered them for you. Now it's really just here because you're not studying the neck. And at this point, to show you that the dens is indeed visible. There's the dens, or that upward extending process from the body of C2. Here is the posterior arch of C1 and its bump at the very back called the posterior tubercle. And move away from it. This is just an interesting thing. This is sometimes done too. If here is the dens, right there, the upward projection from the body of C2. Here's the person's mouth. If you really want to see the dens, you ask them to open their mouth, and you take an X-ray through the mouth. It's called an open mouth view, cleverly, and then you can see the dens beautiful. And the dens can break with various neck fractures. So this is still a decent way to find that. And this is, I'll move on. All right, 50 years ago. 50 years ago when I went to school, if you asked a person what is going to be the major advance in medical treatment and care in the next 10, 12 years, they did give me the same answer you are being given today. Molecular and genetic biology. That's what's going to revolutionize medical treatment and care. It may be true today, but it turned out not to be true 50 years ago. No one would have said the major advance in medical care will be imaging. But absolutely, without a doubt, that is the case. In my lifetime, that is the single biggest change in medical practice is the advancement in imaging. And that advancement is really started out with this device right here, which is called a CT scanner, computerized tomography scanner. Person lies on this table, and the table then is transported through this hole in the donut, which is where the X-rays and the detectors of the X-rays are given off. And they are rotating around here, the source of radiation, and the detectors are rotating around. They were in the very, what's called a third generation scanner. You had the source of X-rays, and you had an arc of detectors, and that just kept on rotating around. In the fourth generation scanner, the whole rim of the donut was made with detectors, and you just rotated the source of X-rays around. And the seventh generation scanner, now instead of having a single row, circular row of detectors, you have 4 or more circular rows of detectors, so it's called a multi-detector array. And still, as in the fourth generation, the X-rays circle around. And then you now have this going on as you constantly slide the table through this, so the actual X-rays are following the spiral as the trunk goes through, and it's called a spiral CT. This is the way it's done now. There might be an 8th generation, 9th generation for all I know now. But what you're doing is you're cycling in circles around the person, getting X-ray images at all these different angles taken around the person, and you send that into a computer, and that computer will reproduce for you a cross-section of the body. And now you can see beautifully what is inside that person. And this is the actual cross-section of a CT scan of a person's abdomen. The only reason it's up here is not for you to know what these things are, but for you to understand that because it is produced by X-rays, the densities are the same. There's bone density, water density, fat density, and air density, just as if it was a plain film X-ray. Here's a bone, here's a bone, here's a bone. This happens to be the body of a vertebra. This happens to be a rib. Here is air all around this person. There's no air in your belly, normally. And then you have fat density, all that sort of grayish, almost dark gray, I guess you call it. That's all the fat of the abdominal wall. And then you have all the mass of this thing, which is water density. All right? So you have different organs here, but they all have the same density. So it's very, well, you can only tell they're different when there's, because of this fat in between them. In your abdomen, there's a lot of fat, which is in between the different organs. And if there were no fat in between them, you couldn't even tell them apart. They'd all just blend together as one thing. For example, here are your muscles of your back. You know there are quite a few muscles of the back. But they all blend together as one because they're all the same water density. Anyway, CTs. How important are they nowadays? Within a year, last year, Stony Brook did 70,000 of them. They almost have replaced physical examination. And this is people are saying this is horrible. Doctors should be trained to do good physical exams. But I don't know how many of you have been to a doctor recently. If you come in with any serious complaint, they'll do a physical exam and then send you for a CT. And that's just it. 70,000 done last year or more. And is it 50 years ago when I was a student? It hadn't been invented. It did not exist. All you had to do was plain film x-rays. Film. It's gone. There's no more film used in x-ray. Everything is done and stored electronically. So there are going to be some films in the lab for you to look at. But the website, especially with CTs, is going to present you the images the way they would be seen if you're a radiologist. You look at it on a computer screen and you go through them with your mouse. And there is no printed copy of anything. Here is obviously a very high resolution, very strong close-up transverse section. You know, the CTs, as I showed it to you, I'm going to go back to this one, that's a transverse section of the abdomen. You know, this thing is spinning in circles around the circumference of your body. A transverse section by radiologists is called an axial section. I do not know why they use the term axial, whereas anatomists use the term transverse. It's called an axial section. So often you will hear this referred to as CAT scans, computerized axial tomography. Computerized is obvious, axial because the section is transverse. Tomography means showing you a cut. Tome means to cut. Anatomy means to cut very thoroughly. Tomography is showing you a cut. Computerized axial tomography. I will clarify why that's not used very much nowadays in a bit. So this is a CT scan, CAT scan if you will, high resolution of a vertebra. All the rest of the abdomen's been focused out of here. It's not in because they're focusing on this. There's no way in looking at this that you could tell me that that's lower half of the T11 vertebra. I knew it's the lower half of T11 because I had the whole series of scans. So I could go up and down and I could count which ones I was at. But I didn't want to give you all the ones above this. So here is, I just labeled you the lower half of T1. And if you cannot tell that that is the body of a vertebra, again, go home and study. Because that's what it looks like. And it's bone density. That's the most important part. Bone density, with the cortical bone around the edge being darker than the marrow cavity bone in the middle. Now, we're going to, see if I can get this to work, we're going to be looking at a series, a CT series of the lumbar spine. And that means we're going to be going down, who's going to do it? Yes, slowly but surely. We're going to be taking a series of sections going down the lumbar column. And we're going to be seeing things that these sections go through one after the other. All right? Obviously, the section at the top is going to go through the superior articular process first. And then as we go down to one of the lower section, it'll go through the top of the body and the beginning of the top of the pedestal. Then we'll go down and we'll get the transverse process and a bit more of the pedicle. Then we'll go down and get the lamina and spine. And then we'll start to get the intervertebral framing. You just have to imagine what this thing is going to cut through as it goes down this section. And I'm going to quickly go through these. This is because we want to focus on the lumbar region. So I'm just going through the ones above that. You can study these at home at your leisure. Here's the real reason I knew that was T11, because this is going to turn out to be the last rib. And you'll see the vertebra below this doesn't have a rib. So that's T12, so I knew the one above it was T11. So let's go down to the middle of the lumbar column, and I'm going to tell you, this is L2. I counted it. You can count it when you get home. This is the body of L2. Let's go look. Yeah, well, no, we'll go here. This is the body of L2. All right? Here's the pedicle coming out the back of the body of L2. Its upper half. Pedicle's attached to the upper halves of the bodies. All right? Let's focus in on this body. Nice bone density structure, nice bone density structure. Down, down. Keep on going down. Down, 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 down. Wow, it went away. There's no bone density structure here. That's a water density structure. So what's that? The intervertebral disc. All right? So that's it. You see the bodies, and then you see the water density intervertebral discs. So this intervertebral disc between L2 and L3. This thing I'm seeing right here is the first thing I will see in L3. It'll be the superior articular process of L3. This is left over from L2. Let me go up the section. I'm going up the section now. You see it? That's left over from, now down again, that's left over from L2. That's the inferior articular process of L2 articulating with the superior zygapophysis of L3. Let's follow this down. Superior articular process, and now we start to see the first or most superior point on the body of L3. And we see a little bit more of the body of L3. Now we just get a hint here of the pedicles coming in. Now we see the pedicles of L3. Now we start to see the transverse processes of L3. And then as we continue, the laminae. We just start to see the laminae and the spine of L3. And these are going to turn into the inferior articular processes as we continue further down. Here they are, the inferior articular processes. We are now just below the pedicle and entering the intervertebral foramen between L3 and L4. And if we follow these bumps down here, these inferior articular processes will articulate with the superior zygapophyses of L4. You can go through this so quickly, it's just not hard, I'm going to not label everything here. I just want to point out a few things. Here's L5, and you'll notice that this is the inferior zygapophysis of L5. This is the superior zygapophysis of S1, and this is the joint between them. And it is angled differently. If I go up a level to L4, here's L4. This is that zygapophyseal joint between L4 and L5. That angle, the surface is angled or positioned in space differently between any of the other lumbar vertebrae and L5 and S1. And that is for a reason. And if the reason is this, if you look at L5 right here, here's 5, 4, 3, 2, 1, 1, 2, 3, 4, 5. It sits on the surface of the first sacral vertebra and looks like it wants to slide off. And it does want to slide off. And it will slide off if you don't stop it. And one of the things you use to stop it is reorienting the articular surfaces. This is clearly the superior process of S1. This is the inferior of L5. The superiors always grasp the inferiors in an embrace. And this inferior of L5 is jammed into that superior of S1 so that the vertebra can't slide forward off of it. Continuing down, we'll get to the sacral vertebrae. We'll get to all of the foramina that I mentioned. Again, there's no point in me dwelling on those things. You can go over those at your leisure. We eventually get down to S4 and S5, where the two laminae do not fuse, and you get the sacral hiatus and the sacral cornea. So that's a complete CT series of the lumbar and sacral spine. I showed you axial scans, computerized axial tomographic scans. That's for, I would say, 10 years, maybe 15 years. That's all you could get from this process, were these transverse sections. Then someone figured out, well, if we really write our computer program in a sophisticated way, we should be able to take the same data that generated that transverse section, and we should be able to generate a coronal section, or a sagittal section, or any section we want. And in fact, now that is routinely done. Those are called reformatted series. So the image that you actually get is a transverse image. It is then reformatted by a computer to produce a different plane of section. That's why since you can easily get coronal sections and sagittal sections, there's no point calling this computerized axial tomography. It's computerized tomography. You can get whatever section you want out of it. Now, so these are reformatted from that same axial series that I showed you. Coronal sections, we're going to start at the very back and go forward. We'll go through it quickly. This is the way the section is going to pass. You can already see it's going to go through the spine first, spinous process, then it's going to get the articular processes and the transverse process and the pedicles and the body, and then you're through. So this is not, again, very difficult. Here's a big muscle, a water density structure. I shouldn't say muscle. Here's a big water density structure. At the back, before, as I'm going from back to front, it's before I get to any vertebrae, so that I'm not going to ask anyone here, is obviously part of the intrinsic spinal musculature that you're seeing on either side. Now we see the first things we've seen in the vertebrae going from back to front. We see the spinous processes. As we keep on going further forward, you see getting closer to the root of the spinous processes, going further forward, and then we come to superior and inferior articular processes. More obvious here, in fact more obvious here. Superior of L3, inferior of L2. There's some lamina stuff here, obviously, lamina stuff there. And as we continue to go forward, you see transverse processes now appearing here, there. Transverse processes. And now we're getting to the region where we're getting pedicles. Pedicle of L1, L2. Because of the bend in the column, you don't see these things simultaneously throughout the column. And then the pedicles merge to the top half of the backs of the vertebrae, and you get the bodies. Not so hard. Here is going to be a reformatted sagittal series. We're going to go from left to right. And I'm not going to make this play out, but we're going to get transverse processes first. Then we're going to get bodies and pedicles and articular processes. Then we're going to get laminae and then spines. So we can just go through this quickly. Transverse processes. We're seeing here transverse processes. Now we're starting to see superior articular process, inferior articular process, superior, inferior, laminae, spines, and then we come out the other side the same way. You go through these yourself, not hard. I'm not going to do this because this is neck, and we don't need to do neck. It's just something, you see such a beautiful atlas, part of an atlas in the dens. All right, something is wrong. Camilla Dagum. Did anyone know why I called on her? You're her, right? You're not? Yes. I called on her, and this is going to embarrass you, I guess, because her father is Alex Dagum, who is vice chair of surgery, a close personal academic colleague of mine, and one of the finest individuals I've ever met in my entire life. It must be terrible to have him as a father. I was the kind of person you wanted to have a father. I got nothing good to speak about. My kids had no problem doing better than I can do at anything. He's really great. You're going to get a lecture from him. He's just a phenomenal guy, and I couldn't pass up not asking his daughter the first question of the class. There's something wrong with this person. I'm telling you that this is the L2, L3 disc, and we're going to go down the series, and we're going to see if you can spot what's wrong with this person. I'll do it slowly. Going down, down, down. I'll give you a clue when we get to the right section. How does that make it easier? Down. These look normal to me. Down. Oops. Something wrong. Down. Something wrong. Down. Still there. The wrong thing. Down. Still there. Still there. Looks normal to me. I'm not. You see? Did you see anything? Something is wrong on the patient's left. Actually, you make it extremely important. We're going to come back to this. You're absolutely right. I must tell you, and I forgot to tell you, with CTs. CTs are shown always as with the patient lying on its back and you looking up from the feet. This will become crucially important when we do other organ systems. You are standing at the foot of the patient looking up. That means the patient's left side will be to your right and the patient's right side will be to your left. That is standard, always done with CT scans. It's done that way because when you look at a chest film, the heart's to your right. So when you look at a CT, you want the heart to beat to your right also when you look at a CT. So that's why CTs are done this way. It's very hard for people to make this adjustment. You want to think of yourself looking down a body and not looking up a body. But you can't have the organs on the same side in plain films and CTs unless you are pretending you're looking up from the feet. So you say there's something wrong on the patient's left, and you're absolutely right. What is that something that's wrong?
It looks like the transverse process might be broken.
She says it looks like the transverse process of L3 might be broken. She has made a correct diagnosis, and that's exactly what's wrong. CTs can see these things clear as day. Clear as day, you can see the broken transverse. Person comes in pain in her back. Patient comes in pain in the back. And the plain film of this patient looks like this. And now that we know what's wrong, we can see it. But if you don't know what's wrong, it's very hard to decide that that is in fact a fracture of the transverse process of L3. It is something that can easily be missed in a plain film and cannot be missed in a CT, one of the reasons CTs have taken over the world. This is a series from a 7-month-old child. Again, I've labeled some things for you. What I want you to notice is here are the pedicles of this vertebra. Here's the body. They are never fused. Here's L3, pedicles, and body never fused. On the other hand, the laminae form and little bitty spine forms. This is a reflection of the fact that in development, the body of a vertebra has a separate bony center, and the vertebral arch has a different bony center. And they don't fuse until you're older. So you get this cartilaginous space. Cartilage is water density. So you get this water density space between the arch of the vertebra and the body, and it's called the neurocentral synchondrosis. I called that, why isn't it called the body arch space? Because in fact, this is called the centrum. This ossification center for the body is called the centrum. The ossification for the arch is called the neural arch center. In reality, a bit of that neural arch center right here becomes part of the adult body. So this, I sort of lied to you, and I called this the body and called this the pedicle, but in fact, in reality, when these fuse, when you're about 1 or 2 years old, this will become part of the body, and then this will be the pedicle here. Anyway, you should realize when you're looking at a young child's CT scan that they don't have fractures at every single level between the arch and the body. Here's L5 of this person. We look at L5 laminae. Looks to me like the L5 laminae are getting very close. Very close. Oh, damn, they're just not fusing. S1, they're not even getting close. S2, not even getting close. S3, whoa. This person has a serious defect in the sacrum with the laminae not fusing. Here is something called volume rendering. This is, again, something within the last 6 or 7 years. They've now figured out a way to take all of this computational information, reconstruct 3D representations of it, apply nice colors to it, and give you what's called a volume rendered image. And this is a volume rendered image of that person. And you can see the big gap in its, you can see lots of really neat things there. But first of all, you can see the nice neurocentral synchondroses at every vertebra. And then if we get to the back view, you can see that failed L5 laminal fusion and the very abortive sacral ones. This is a spina bifida. If you did any embryology, you would know. This is a spina bifida that this child had. We saw some of it in the CT, but it can be seen much better. The soft tissue components can be seen much better with this technique. How old is that? 15, 20 years. This is an MRI machine, magnetic resonance imaging. Those of you who are physicists may understand this. I do not understand how it works. It works magic by magic. It relies on the fact that spinning protons are little magnetic dipoles that can line up with things and be deviated and give off radio signals, and I don't want to get any more than that. Magnetic resonance imaging is a world apart from CT because there's no x-rays used. That means all those densities that we learn, here is the CT of that child with the spina bifida. All the densities we learn, bone, air, fat, don't apply at all. Things are very different in what is white and what is black in a magnetic resonance imaging. And furthermore, there are different types of magnetic resonance imaging. There's T1 and T2. And this is important, and then I think I'll go through some of the other stuff very fast. T1 imaging in both T1 and T2, and in fact, all magnetic resonance images. This white stuff, which we know to be bone in an X-ray image, is black. That black line there and that black line there, that's bone, thick cortical bone. Here as well. This soft tissue water density stuff is sort of a dark gray. These are all muscles. But see, now you can actually see clear. Fat, very bright white. Fat was almost air density in a CT. Fat is extremely bright in MRI. Extremely bright. Bone is dark. Fat is the brightest. Bone and air are the darkest. Standing fluid, if it doesn't have a lot of protein in it, is also dark. Fluid that has a lot of protein in it may be gray. That's in what's called a T1 image. In a T2 image, it is the same. Air is black, bone is black, fat is white, but standing fluid in a T2 image is white. So we're seeing a T1 of this child and a T2 of this child, and what we're seeing is what this funny looking thing on the CT really is. It's a little cyst, a cystic sac. It's a meningocele. And the reason it looks black here is because this is a T1 image where the standing fluid is black. And the reason it looks white here is because this is a T2 where the standing fluid is white. Here's this child's urinary bladder. Looks black here. Here the urine is white. So he's got a lot of urine in his bladder, but you can tell in a T2 image it doesn't show up in a T1. We'll be doing a lot of MRIs in the future, but the important thing you realize is the gray coating does not follow CT at all in any way, shape, or form. Air and bone, black. Fat, bright white. Standing fluid, black in a T1, white in a T2, and water density things are just gray. MRI is what you do when you want to find out if a person has a slipped disc. And you do that because, look at this. The discs stand out beautifully in MR. They were just water density, nothing in a CT, but in an MR, the nucleus pulposus, in a T2 weighted MR, the nucleus pulposus stands out as bright white. It's sort of gray in a T1 because it's a protein fluid. The annulus fibrosus, which is just thick connective tissue, connective tissue is black in an MR. So the annulus fibrosus here and there, that's black. You can see a disc so beautifully. You'll have to go on the web to get these labels because I just don't have time. The reason you do an MR of the lumbar spine is to look for abnormalities in the disc. And here's a person who has an abnormality in the disc. And I will, in fact, be done in exactly 2 minutes. Here's a T1 weighted and a T2 weighted sagittal section, MR You see the cerebrospinal fluid in the T2 is white. Cerebrospinal fluid is sort of gray in the T1. But look here at this disc, how it's bulged out the back. And look at that disc, how it's bulged out the back. That's what a disc should look like. It should have a nice smooth annulus fibrosus posterior border. This one has a bulge and a bulge. And if you go all the way down to a transverse or axial section MRI, here is the bulge in the disc we saw earlier, the bulge at a different level. MRIs of the lumbar spine are the way you diagnose herniated discs. All right, so we've got to quit now, and we'll go through MRIs more later.